Alright guys, this is a very high yield slide. We'll go through the fetal circulation. It is another subject that I remember particularly well because it appeared on my Step 1 exam twice. It is highly testable material due to its ability to test your knowledge of the normal fetal circulation and the changes that occur at birth before you eventually finish with the expected result of progressing towards normal adult circulation. So I'm going to show you this diagram, highlight the flow of blood with the arrows, pausing to explain some important high yield facts along the way. Important high yield fact number 1. The fetal blood that is coming back from the placenta via the umbilical vein is oxygenated to the point that it's 80% saturated. So here at the placenta, the maternal blood meets the same interface that the fetal blood interacts with, and they exchange oxygen. Because fetal hemoglobin is made of alpha-2 gamma-2, and therefore has a higher affinity, pulls the oxygen, and it is 80% saturated as it enters the umbilical vein on the way towards the fetal part. The blood in the umbilical vein has two options. It can travel to the liver sinusoids and provide oxygen and nutrients to the hepatocytes. That is option 1. Option 2 is to completely bypass this via the ductus venosus. So here are two options, 1 and 2. A branch of the umbilical vein that supplies the right lobe of the liver is actually joined by the hepatic portal vein, as you can see here, at the right inferior aspect of the liver. It's not shown very well in the diagram, but I'm just mentioning this for completeness so that if you see it in another resource, you have already been exposed to the information. It isn't necessarily vital for your understanding of what is important here, so let's continue with what's important. Again, we need to focus on how the circulation is normally, the changes compared to adult, and things that can go wrong. Deoxygenated blood that leaves the hepatic sinusoids will coalesce into the hepatic vein, which will join the blood that is coming across the ductus venosus that is still oxygenated at 80%, so they both join in the inferior vena cava. The blood that went to the hepatocytes and the hepatocytes extracted oxygen and nutrients from, combined with the blood that remains 80% saturated that went into the ductus venosus, combined in the inferior vena cava. In summary, the blood that bypassed the liver via the ductus venosus will also be dumped into the inferior vena cava. So there's mixing of deoxygenated blood that passed through the liver and oxygenated blood that bypassed the liver via the ductus. So now we're continuing in the IVC. There's actually a small valve, which is a component of the crista terminalis, right where the IVC enters the right atrium. And this kind of creates a nice little vector of blood flow, so that the blood that is coming from the inferior vena cava will be directly shunted across the foramen ovale. That little valve that shunts blood into a vector will help guide flow to the foramen ovale. Why is this important? Well, it helps guide a majority of the blood across the right to left shunt, so that the left atrium and left ventricle can transmit blood into the aorta. This blood that is entering the aorta before you hit the ductus arteriosus will provide oxygenation to the structures supplied by the aortic arch. So we know that the right innominate gives the right subclavian, which supplies the arm, and then the right common carotid, which goes to the structures of the head and neck. And then we have our left common carotid, and then our left subclavian. So the blood that is coming from the inferior vena cava is shunted because there's a nice little valve here from the crista terminalis that will push the blood from the right atrium to the left atrium. It can go into the left ventricle and then be ejected directly into the aorta. This is highly efficient because the head is the most important part, period. You need to make sure that there's oxygenated blood being shunted across and directly into the left atrium, to the left ventricle, and the aorta to perfuse the upper extremity, the neck, and the head. So why are there so many other arrows on your Step 1 diagram? Well, not all of the blood that enters the right atrium will go through the foramen ovale to the left atrium. Even though the pulmonary vasculature is contracted and thus highly resistant to blood flow, the pulmonary tissue is still developing and needs to have some oxygen and nutrients pumped into it. In addition, the blood that is emptying into the superior vena cava is deoxygenated blood because it is returning blood from the upper extremity, the head, and the neck. So there's some mixing of very low saturation of saturated blood from the superior vena cava with the inferior vena cava that is supplying the oxygenated blood. Some of the blood will mix and then it will enter the right ventricle. The right ventricle will pump into the pulmonary trunk and there will be flow, some into the lungs, very minuscule amounts, but the lungs are still developing tissue. They need some blood flow and nutrition. The rest will directly enter into the ductus arteriosus and continue down into the systemic circulation via the descending aortic arch. So this is a very unique situation in which you can directly shunt from your right atrium into your left atrium via the foramen ovale, causing blood to go into the left atrium, left ventricle, and then supply the structures of the head and neck. And there's also a nice little combination of flow that occurs when blood is coming in from the superior vena cava that will travel into the right ventricle, into the pulmonary trunk, and then some into the lungs, and then the rest will go into the systemic circulation via the ductus arteriosus. Alright, so I broke this next section of fetal derivatives into 2 slides because it's such an easy way to get you. Even if you know all the physiology and anatomy behind these organ systems, test examiners will love to present some sort of anatomical question, and just when you think you figured out what they're going to ask you, whether it's about the anatomy of the portocaval anastomoses that can occur in a cirrhotic patient, in your vignette, you keep reading, and then you get to that buzzkill moment when they ask you for the embryological derivative listed that participates in a portocaval anastomoses responsible for your cirrhotic patient's presentation of something like caput medusae, which they could potentially show you in an image. Examiners expect you to know those portocaval anastomoses because they can cause a very classic presentation. The venous dilatation, where there are these anastomoses between the portocaval vessels, is very prominent because you will see it when there's backup of blood and increased hepatic portal vein pressure in a cirrhotic patient. So let's remember, fibrosis that occurs in a cirrhotic patient will compress the central veins of the hepatic sinusoids. So you compress that central vein, and there's now backup of blood pressure into all of the components of the central veins that coalesce and are actually going to connect to the portal vein, and that is how they are fed. As you can see, there's tiny little branches of this hepatic portal vein. So let's review some of these anastomoses, because this is a great way that they could potentially incorporate some embryology. Remember, portal hypertension causes problems in the butt, caput, and gut. I'm not really one for mnemonics, but it has butt in the mnemonics, so I thought it was entertaining. So the portal hypertension will cause blood to back up into the hepatic portal vein, again here, and this will cause problems due to such high venous blood flow where the esophageal branch of the left gastric vein meets the esophageal branches of the ascicus vein. Also where the superior rectal vein meets the middle and inferior, and where the para-umbilical meet the superior epigastric vein, and where the right, middle, and left colic veins meet the renal, suprarenal, paravertebral, and gonadal veins. There's an incredible amount of information that can be tested from a single embryologic derivative, and it's all fair game. Something that you could potentially be tested on are the remnants of some of these structures, changes that occur at birth, complications that occur at birth, and how to treat them. All of these structures will have fibrotic proliferation and close, so they become like ligaments, and that is why a majority of them have the name for ligament in Latin as a part of the name. So let's start with the old ductus venosus. We just talked about it because it carries oxygenated blood from the umbilical vein directly to the inferior vena cava. How oxygenated is the blood in the umbilical vein? 80%. So this umbilical vein supplies 80% saturated blood to the ductus venosus. The ductus venosus closes during the first week of life, and its remnant is called the ligamentum, again because all of these close by fibrotic proliferation and therefore they become ligament-like structures. So it's called the ductus venosus. Might as well call this the ligamentum venosum. It is not represented by anything in this diagram. A great way that test examiners would like to trip you up is the fact that the ligamentum teres hepatis is in a very similar location where you would expect the ductus venosus to be. They might show you something labeling the ligamentum teres hepatis or something labeling the ligamentum venosum. They're not the same thing. The ligamentum teres hepatis is also known as the round ligament of the liver, and that is where you make the connection that it is the remnant of the umbilical vein. Within the umbilical vein that becomes the ligamentum teres hepatis or the round ligament of the liver are actually where the para-umbilical veins are that participate in the portocaval anastomoses. Alright, what about the foramen ovale? It will close off and just leave a nice little concavity which is called the fossa. Remember, the foramen ovale, close off, with a small concavity called the fossa ovalis. Fossa means small indentation. The ductus arteriosus, which carries partially deoxygenated blood from the pulmonary artery to the distal segment of the aortic arch, will close off and become the ligamentum arteriosum. Again, all of these close by fibrotic proliferation. Like ligaments, they are made of collagenous tissue when they close off. It was called the ductus arteriosus. Makes a lot of sense that it's called the ligamentum arteriosum. Same thing with the ductus venosus, becoming the fibrotic remnant, the ligamentum venosum. So this is a great time for us to tie in some anatomy. What structure loops around the aortic arch posterior to the ligamentum venosum? I will give you a small question like a vignette that you might get to help remember this. A man comes in with a large murmur of aortic regurgitation. So he's regurgitating blood retrograde from his aorta into his left ventricle. He notes that his voice has been particularly hoarse for the past couple of months. Do you know the structure now? Well, take a study break if you said recurrent laryngeal nerve. You earned it. Think back to your anatomy and how the recurrent laryngeal controls all of the intrinsic muscles of the larynx except the cricothyroid. It loops right here where the aortic arch is, and the remnant of the ductus arteriosus is sitting, the ligamentum arteriosum. What they wanted you to know is that the reason for this patient's hoarseness is that there was dilation of the aortic root. And that is why he has aortic regurg. If you dilate that aortic root, you're going to eventually have enough regurgitation over time that you will cause accumulation of blood within the left atrium. Because pressures will back up from the left ventricle into the left atrium, and then you will eventually dilate this left atrium over a long period of time, and it can compress that left recurrent laryngeal nerve that is responsible for innervating the intrinsic muscles of the larynx, except the cricothyroid.